Most breast cancer plans are guesswork. They're not deeply mapped, and you're not really getting the immune system involved, which is critical. And those tumors can be resistant. So this is how we handle stage 4 breast cancer to target it so we can comprehensively treat it and get the response we're hoping for. I'm Dr. Dino Prato. For the last 25 years, we've worked with many breast cancer patients, and we've helped them with deep mapping and immunotherapy-centric care. And today I'm going to show you a simple playbook that has worked for so many of our patients. So here's the problem we have. Many patients have already tried chemo, unfortunately, and their bodies run down. Their immune system is weak, or they've grown drug resistant because of too much chemo, or they have just done integrative natural care and it hasn't worked for them. We've seen all of this over the years. Patients who've come from the top hospitals with difficult issues. But here's the problem that occurs, and I'm going to sound repetitive because I've said this before. They don't have deep mapping, and they don't know what's causing the cancer, which could be infection, chemical toxins, heavy metals. Just a recent published paper in 24 that linked Lyme disease to breast cancer. We've been looking at this for 2 decades. Finally, there's a paper supporting that. They found the actual infection inside the biopsy of the breast tumors. So infection is a big player, but at the core of this, it's immune system centric. When you get the right immunotherapy with breast cancer, it's a game changer. And guess what? There isn't many immunotherapy drugs for most breast cancer. Only in triple negative breast, in certain scenarios, you might get access to a PD-1 inhibitor. Long-term response, maybe a 19% with patients. That's not very good. So how do we change that? Well, there's a couple things you should know about breast cancer. First of all, breast cancer has these stromal, oftentimes barriers. It can be very fibrous. We test for this in very advanced testing, and we can see that the chemotherapy never got to the tumor. It doesn't get there very well. The cancer is pumping out the chemotherapy, and the immune system is totally being evaded. Precision testing is so different than what you're used to. In standard testing, you're getting a biopsy, a tumor marker, and imaging. Let's call that 20 data points at the best. And if you go to integrative care, they might be testing a few other things, but not at the level I'm about to go into. Now, you might have been lucky enough to get your doctor to run a DNA test, and that's only a few hundred markers, but it only tells you about these particular drugs that may slow things down. Not necessarily kill the cancer, but they're cytostatic, not cytotoxic. And we're not going to get to the remission we want unless we kill the cancer, and that needs to be in the algorithm. With precision testing, we change the entire game. It's totally advanced. DNA, NGS, next generation sequencing, RNA, transcriptomics, and immune spatial biology. I'm going to try to explain this in a powerful but simple analogy. You can send a drone up in the sky to see the entire cancer and all of the cells around it and in it. And when you see that, you can see the deep map, finally, why the treatment isn't working. The DNA is the car driving through the city, like you're looking at the city map. And the DNA can be broken, but the drugs that are approved for those are very few. So we have to look at off-label and phytotherapeutic and immune therapy drugs that we custom design for the patient. So you're not going to be able to just order those. Those have to be custom made in our compounding pharmacies for our patients. The same thing is true now. We look at RNA. RNA is who's driving the car. It's where the cancer's going. What is it doing right now? What is it resistant to? And if you shift that, all of a sudden therapy is going to work so much better. And the same thing, we have to custom make those drugs. And then with immune spatial biology, so we can bring in the SWAT team of the natural killer cells and dendritic cells, your God-given immune system to fight the cancer, we need to alert them, strengthen them so that they can find the cancer and get rid of it. That's huge for breast cancer. So oftentimes we can deliver it straight to the tumor. Once we know what's going on, now we develop custom medicines to go right to the tumor. We can take a catheter the size of the hair, go right to the tumor, kill it, come out with a Band-Aid. And that tumor now dies, and we get an immune system response to the body to go after cancer. It's not uncommon where we treat breast cancer in just one area of one breast, and the next breast is already dissolving. The tumor is gone because the immune system response is happening throughout the body. This is the key to immunotherapy. This is the bottom line of what's missing in breast cancer. The sooner precision medicine is put into play, the better it is. Yes, there's a whole lot of tests out there, especially around breast cancer, but they're not deep. They're not looking at thousands of markers. They're not taking the algorithms of these pathways, customizing them, custom building the medications, and then delivering them for those tumors. So this is the important thing, because we want to turn on the targeting. We want to get the guesswork out. We want deep mapping, and now we know where we're going. And then we want to do what's called adaptive monitoring. This is so important because now we can tell if the treatment's working. Not wait for just imaging for the tumor or wait for tumor markers. We can look at circulating tumor cells, methylation scores, which shows us treatment's working, cancer's dying. And we can look at inflammation and stress signaling to see, hey, this is moving in the right direction. Now that we're moving in the right direction, let's keep doing this and bring this patient to the good health and maintain it over time. That's the goal. And so we do that in several ways. If you have a good target, and we have targets for chemotherapy, even when we deliver those, it's in micro doses. Genetically targeted fractionated chemotherapy is very special special because not only is it targeted based on this deep mapping, but then it's in microdoses so that we get the release. Think of your cancer is going to be squeezed like an orange, and the antigens or the information of that tumor gets passed on to your immune system. Remember, the immune system is the key here. And the immune system picks up these damage-associated molecular patterns with these stress signals, and then it passes it to the immune system to go find the cancer everywhere in the body and at that tumor and take it out. That's why that's a very special way, particularly in breast cancer, to treat. And then getting direct to tumor, because some of these tumors are stubborn. They have fibrous walls around them. They have stromal barriers and you can't get to them. And you can watch my video, The Great Wall of Cancer, which talks about these barriers that are in so many cancers that you just, no matter how much you do IV chemotherapy, it's just not going to get there. And it's going to be less than 2%, 5%, in some cases, 0.7% absorption. You can get right to the tumor now, get the medicine you need that's genetically targeted, get the immune response, and just do it. It's 45 minutes, come out with a Band-Aid, it's targeted. And you don't get all that toxic chemotherapy to the rest of the body. It's right where you need it. Seal the blood supply using interventional radiology oncology with 3D tumor imaging. We use these incredible 3D cone beams to visualize all the blood supplies going into those tumors and get them right at the right spot and seal them. So powerful. And then enacting the immune system. Just had a case recently. It was breast metastasis to the brain and to the bone. And it did so beautiful. We built a biologics immune therapy for them. It's called AAIT, where we basically took their natural killer cells, dendritic cells, grew them, their own cells, connected it to their own DAMPs, these damage-associated molecular patterns, to the billions and their peptides, and put that back into the patient. And for that patient, that response was beautiful. Tumor shrunk, full clearance of the tumor. You can see in a PET scan before and after, totally clear. That was the power for that particular patient. So everybody's a little different, but where were they going to get that therapy? That's a special immunotherapy that needs to be done in certain cases. So it's these combinations of this data that tells us what to do. And if along the way, let's say you have a highly, highly resistant cancer that's mutating very quickly, we're going to be testing for that. We're going to be able to spot the mutation right when it's happening, modify care just so gently so we stay on course so that that cancer can get the treatment it needs. This is the power of precision. This is the future. It's like taking deep learning, AI, all the best top algorithms and bringing it into your cancer treatment, which is not happening right now. I can tell you, all the top hospitals in the world, they are not doing this. This is not what's happening. It's still the world of big pharma develops one drug for a certain cancer type, maybe a marker, and it takes a number of years and it gets to the patient and it doesn't do what we want it to do long term. All the studies, all the data, we're adding a few months maybe to a patient's life. If we're lucky, 3, 6 months, that's a lot. But we need to go beyond that. And the key is immunotherapy, immunocentric care, particularly with breast cancer. Then it's monitoring it. And then, in addition to that, as I mentioned, we use the liquid biopsy, the CTCs, CT-free DNA, we use methylation scores. So we're on top of that cancer before we even see an image of anything. We already know what direction the cancer's headed and we can intercept that. But what's so important is what's caused the cancer? Was it chemicals, heavy metals, infections? I'm going to tell you something that's very interesting. Most of the patients we see have some sort of infection with cancer. And if you look at the World Health Organization, they only say 13% of patients have infections that cause their cancer, or maybe 30%. But it's much higher than that. And I'll tell you why. No oncologist is testing for infections at the level that we test for. They're not looking for viral, bacterial, fungal, tick-borne illness. They're just not doing it. And most doctors aren't either. When we test, patients have these infections that are suppressing their immune system and making their cancers grow. They have chemical toxins. They have inborn errors of metabolism. They can't metabolize medicines well. They have poor cytochrome or glutathione pathways of the liver of elimination, inflammatory pathways and networks that are off. All these things are anchored into the treatment that we do so that we're able to get to the root causes and treat them from the root. And when you know that with the deep mapping, now not only can you help the cancer be silenced short term, the goal is to silence it long term because you know what the drivers are. You've gotten the guesswork out and now you get the targeting that you're hoping for. That's the goal of precision planning. That's why breast cancer should be done like this all over the world, because this would change tremendously what we're seeing with patient responses. We'd have better responses. We'd have care that's detailed, layered, and precise. And we would not be guessing. We would be bringing more life into patients, better quality of life, as our paper showed. And as I said, in 2024, we published a paper and we had 35 times better response in late-stage cancer, 35 times than conventional care, and 43 times quality of life. And that was in 24. Today, we're even better. We're actually going to publish another paper here soon. And that data is because of the precision targeting is allowing us to just solve these puzzles for our patients. This is what patients deserve. And I really believe this is the key to changing the world of oncology. I hope this was helpful, and may the Lord bless you on your journey to healing.